be forwarded to Professor Jorn, and if we have time, he will answer it, inshallah. Professor Jorn, you have the stage.
I've got the stage, yes. Thank you. Can everybody hear me? Yes. Can you hear me? So, yes, thank you, Professor Jarber, to introduce me. And we've known each other for a long time, and I'm very happy to be invited to give another lecture today. Thank you also to Professor Awad, who joined us here. We have worked together many years, and I could call you a friend, I think. And I'd like to talk today about a topic that is often a bit forgotten and a bit neglected. I'd like to talk, as you can see on the screen, about multimodal neuromonitoring. And I want to answer the question, do we actually need it and how should we do it? And what do we monitor and what should we actually do? So I'd like to split the lecture into 4 big parts. One is the general aspect, why neuromonitoring at all? What is it and what are we doing and why are we doing it? The second is, why are we actually doing multimodal neuromonitoring, meaning not only one entity of measurement. The third is, which parameters should we actually measure and can we measure? And the fourth is the integration and visualization of data. How could this be done? So in general, I'd like to talk about general parameters, about ICP and about PO2. I'll get into that a bit later. So I will concentrate on those 2 aspects mainly. So what's the main problem here? The main problem in our specialty or in medicine in general is there is an accident. There is a big occurrence. There's an event which I call the primary insult, which is an accident like the tsunami wave here, but you can also say a traumatic brain injury, for instance, or an acute subdural hemorrhage is a primary insult. And the problem is that we can't really do anything about that because that has happened already. But everything afterwards is something that we can actually influence. So we have the primary insult, and this leads to secondary damage. So what we do is we have to assess the situation, we have to expect any complications, and we have to diagnose these complications, and then we can treat them or maybe even avoid them. So that means you have the primary problem and the secondary damage, and here where these arrows are, that's where we can actually intervene. And that's where our problem comes to light. So the main problem is we want to avoid problems. We want to diagnose problems, and we want to start a certain treatment for those problems. And it's mainly circulating around secondary brain damage that we want to avoid. And this is very often related to cerebral hypoxia. So there's a variety of conditions that can actually cause secondary brain damage. They have a variable time course, and they need to be fast. The diagnosis of them needs to be fast. They have to be quickly diagnosed, and this is very crucial to instigate an optimal therapy. And this can only be done by continuous monitoring of a variety of clinical parameters. As I said, primary damage has happened, can't do anything about it. Secondary damage will happen, and we can interfere. But we have to diagnose it. So that means we have to get the diagnosis as early as possible before a reversible damage occurs. So what can we monitor? So there's a couple of parameters that everybody basically does monitor already on an intensive care unit, for instance. This is the arterial pressure, the perfusion pressure that can be calculated out of that, cerebral perfusion pressure, blood counts, oxygen saturation, temperature, and so on. There's other things that are more specific for our specialty, for neurosurgery. This is intracranial pressure. This is oxygen pressure in the tissue. This is changes that occur in the transcranial Doppler. That this could be changes that can be measured in on the molecular level, which is measured with microdialysis, and possibly cerebral blood flow. So the continuous monitoring of different parameters is crucial here, and I want to stress that the routine clinical examination is still never to be replaced. Why should we concentrate on multimodal monitoring? Which means why should we not only do one parameter, but maybe a couple? What benefit brings that to us? So there's a study, for instance, they looked at 53 patients with traumatic brain injury, and they found in these patients that they did not significantly differ in cerebral perfusion and ICP measurements, but when they measured ICP only, intracranial pressure only, they found that they missed a couple of patients who got worse. So they looked at two groups, and one was only measured, one had only the ICP measured, and the other group, which were roughly the same size, had the PO2 of the tissue, we get into that a bit later, measured, and they found that there was a difference, and that difference was actually significant. So that led them to the conclusion that ICP and PO2 should be monitored simultaneously, and a PO2 directed care was even associated in this study with a lower mortality. So let's go to the first parameter. Let's go to the intracranial pressure. In general, the intracranial pressure is similar on a global level in the brain. It depends a little bit of the location of the probe, but in general, you can actually say it is the same supratentorial, roughly. There's a slight change in front supratentorial, of course, but and sometimes on the side, of course. For instance, in extradural hematomas and so on, but in general, you can say it's relatively similar in the cavity of the head, and there is a relatively well-defined relation between intracranial pressure and Glasgow Outcome Scale, for instance, but it requires a monitoring system that should be used for this entity to be measured, and this monitoring system has to be accurate, safe, robust, cheap, and if you want to integrate it into a wider system of measurement, it should be compatible with a multimodal monitoring system. So in general, the normal pressure is above 70 to 200 millimeters water, or 7 to 20 centimeters water, or 690 to 2,160 pascals. The measurement is usually done, as we all know, by a lumbar tap, but in neuromonitoring, we can't just do lumbar taps all the time. So we have to put in a continuous measuring device, which is an ICP bolt. And a lot of people will have heard about this. ICP bolt will be inserted into the brain. And there the normal values are slightly lower than above, but they're roughly these measurements. We have rhythmic fluctuations. I'm not going to go into this because this is just physiology. So how can the intracranial pressure be monitored? There are basically three big ways of doing that. One is the intraventricular measurement, which is relatively easy to do because a lot of us put in intraventricular drains. That's also the advantage of that. You can actually treat increased intracranial pressure with an intraventricular drain. and you can measure the CSF. If you put a pressure transducer on that system, you can measure it at the same time. The disadvantage is that there is quite an infection risk involved, and it needs a proper operation to insert the probe normally. The second way of measuring the ICP would be the intraparenchymal measurement, where you actually insert some probe into the brain parenchyma and do the measurement constantly with this probe. So that this kind of measurement has the benefit that the infection risk is relatively low. You have a relatively low risk of bleeding. It's done quickly, and the measurements are relatively stable. There is another way of measurement the ICP, the intracranial pressure. That's the subdural measurement. That can be sometimes technically difficult, but if you know how to do that, it's also a valuable method to be adopted. So again, the normal values down there. So different measurement systems, I don't want to go into the different ones. I like the probe ones, the pressure sensitive probes the most, because they're very, very stable, but some people use optical transducers, some people use transmission via airfield tubes and so on, but I think most people probably use the middle one, the sensitive probes. Why should or do we measure ICP alone, or should we measure it alone? And there are a couple of studies, and this is just an example of the studies, quite an old one from 1998. They looked at a number of patients, and they did a continuous recording of all different parameters, PO2, ICP, CO2, and the cerebral perfusion pressure. It was done in Berlin, I think. And you see the results here. I don't want to read them all, but in general, what they found is that that ischemia is actually possible with a normal ICP. So the ICP increase is not necessarily always seen in patients that develop cerebral ischemia in the end. So they concluded from this study that the PTO2, the tissue oxygen pressure, is an independent parameter following traumatic brain injury, because they saw differences in that patient groups. And that gave rise to the idea of maybe measuring both of those parameters. So how can the PO2 be measured in the brain? So there, in the neurosurgical or neurointensive setting, there are basically three big methods. One is the jugular venous oxygen saturation, which is basically that you place, I don't know if everybody has seen that, place a fiber optic catheter in the jugular vein, and you basically measure the arterial venous difference of oxygen. It's normally roughly around 60 to 90%. And if it drops below 50, it indicates cerebral ischemia. It's relatively technically demanding to do that, and you have to adjust the system quite a lot and calibrate the system quite a lot. Then there's another method. This is completely non-invasive, which is the so-called near-infrared spectroscopy, where you actually basically put a probe on the surface of the head and use light fluctuations or the reflection of infrared light to determine the oxygen saturation through the intact skull. I've done this quite a bit, and it's quite difficult technically, and you lose a lot of data because you have to readjust the system quite a lot and so on. But it's possible. And then there's the tissue oxygen measurement, and that's called maybe people have heard the name LICOX, liquid oxygenation probe, that is actually inserted into the brain. I'll go into this in a minute. If you compare the three methods, this here is quite interesting. If you look at these, I don't know if you can see my arrow here. I hope so. Down here, the time of good data. There's a study that they compared the three methods in groups of patients, and they saw that the time of good data, they looked at how long the probes were actually in place and how much of the data could they actually use, which of the data could actually be used to determine the situation. And here there's a huge difference. Only 50%, roughly 50%, would be usable with near-infrared spectroscopy, whereas 95% of data could be used with tissue oxygen measurement. So that shows a clear advantage of the tissue oxygen method. So I want to go into this a bit more now. The Lycox is called Lycox because liquor is the German word. It was developed by a German company initially, and liquor is the German word for CSF. So that's why it's called Lycox. So it's basically CSF oxygenation system, if you want. It's a so-called Revoxode. It records the O2 partial pressure in the tissue, and initially it was developed for CSF monitoring by a group near Kiel in Germany, and they called it Lycox, but actually they changed from CSF monitoring to tissue monitoring because, as I will talk about in a minute, this is a bit more accurate. The basics are you measure the interstitial oxygen partial pressure, which is basically that we measure the oxygen that's available for consumption. It doesn't say anything about how much is consumed, it doesn't say anything how much is getting into the tissue. It's just telling us how much oxygen is in the tissue where the probe is, basically. So it's a local measurement, but we can make some conclusions about the global oxygenation of the brain as well. It is a very good indicator for the availability of cellular oxygen, but not the consumption, as I said, because the consumption can also be influenced by other parameters like pH, or if there's an intoxication and so on, that can actually change the consumption of oxygen in the brain tissue, for instance. Normal values are about 30 millimeters mercury. We get into that a bit later. And yeah, the principle is it's polarographic. I don't want to go into the chemical reactions, but it is basically a probe that you insert in the brain. This is an old one. They have a newer one now, and it's an electrochemical reaction. It has a low zero drift, so it doesn't change a lot over time, and sensitivity is relatively low over time as well. So it's relatively reliable. So as I said, they developed this method for ventricular CSF, actually, and as a parameter that's representative of the global PO2 in the tissue. But basically what you do is if you put a probe into the ventricles, you actually measure the oxygen, or you get a reading of the oxygen that's in or around the choroid plexus. And here the normal value is 60. And that was how they started. And then they realized that it is very difficult to use this parameter, and it might be much more useful to use the tissue PO2. And they found out that the PO2 in the tissue is actually much more reliable. It's much more easy to measure, and especially because you have patients where the CSF is drained, for instance, and you can, or when the ventricles are small due to brain swelling, for instance, you can't really measure the proper CSF PO2. That's why they went into the tissue, and here they found out that the normal value is about 30 millimeters mercury, so it's about half of that, and that also gives us some ideas if the probe is in the wrong place. For instance, you can sometimes measure too high, get too high readings. So here again, the oxygen pressure in the tissue versus the oxygen pressure in the ventricles. You have a relatively good correlation in normal brain tissue, but in general hypoxia, the tissue oxygen might lag a little bit behind, and it depends, of course, on the tissue damage. So when you put in a probe like this, you don't want to put it straight into an infarct, for instance, because you don't measure anything. So you always have to go into the penumbra to see whether this infarct is getting bigger, for instance. In general, the PO2 in the tissue is more reliable. So the pro and contras of that measurement method, of the PO2 measurement, is that it is relatively stable and reliable. You have few artifacts, the complication rate is relatively low, and you can easily integrate the whole system into a multimodal monitoring system, which brings all the different measurement modalities like ICP, PO2, and so on together. Contra against the using of the method is that it's relatively new. You need a bit of experience, and it's actually a local measurement. You have to always be aware of this when you interpret the readings. And you also have a time delay of the measurement, because if you insert the probe, you have to wait for a certain amount of time because of the trauma you actually create by insertion of the probe. It takes up to half an hour, until you can actually use the readings properly, sometimes even a little bit longer. And it's sometimes not really cheap. So indications for use of PO2 monitoring is in anything that has anything to do with O2 and with ischemia. So mainly that comes to light subarachnoid hemorrhage, vasospasm monitoring during therapy or of cerebral vasospasm. You can look at it, look at the PO2 in traumatic brain injury management to guide your treatment and to guide your treatment decisions, and maybe your medical therapy, for instance, or your ICP management. So you use the PO2 as an add-on to the ICP measurement. You can it can help you with decisions for invasive therapy, for instance, decompressive hemicraniectomies. And you can, in the neurological field, you can look at cerebrovascular incidents and ischemia events and monitor those patients. And you can also do an intraoperative PO2 management in vascular neurosurgery. I'd like to go into two groups, divide this all into two groups. One is the subarachnoid hemorrhage treatment and the intraoperative PO2 measurement. If you look at subarachnoid hemorrhage and at the morbidity and the mortality after aneurysmal subarachnoid hemorrhages, you can actually see that after the initial bleeding, which is our primary event, which we can't really do anything about, the two big points are actually that define the complications, that define mortality and morbidity, are surgical complications and even more vasospasm afterwards. So for this, we might be able to use this monitoring. If you look at, you can do some intraoperative monitoring, and there are a couple of studies, if you do a literature search, where they used tissue oxygen monitoring during aneurysm surgery, and they found PO2 to be beneficial. If you look at this, for instance, here, then if this red arrow shows the temporary clipping before the definite clipping of the aneurysm, and you can actually see, if you put an oxygen probe in, you see an instant decrease in oxygen level in the tissue, which can be monitored with your O2 probe. Problem with this whole intraoperative business is that you again need a run-in time, so you have to insert the probe very early in the beginning of your surgery, because if you're fast and if you do the operation relatively fast, then you might not get correct readings. But an hour I mean, often the operation takes more than an hour until you get to the hot part of the surgery. So, otherwise, the benefits are potentially that you have a very good stable measurement once it's once the probe is established, and you don't need to recalibrate the whole system there. So we do use this in simple. We do not use this method in simple aneurysms, but if there's a complex surgery with a likelihood of prolonged temporary clipping, we do use the PO2 probe and put them in the territory at risk that we are afraid of damaging during the clipping, and because then if you see that the PO2 goes too low for too long a time, you can maybe open the clip for a while and relax for a while, and then continue the operation a bit later. So then post-interventional monitoring, that's much more important actually than intraoperative monitoring. You put in the probe after you had an intervention, and you can, I just put this in here, there are a couple of studies if anyone wants to have a look at it. There's very good correlation of PO2, which is the blue line here, of the curve of the PO2 measurements to cerebral perfusion pressure and regional cerebral blood flow. So you can use this measurement, which they are quite difficult to measure. So the PO2 is easy to measure when you put that probe in, and you can get a very good correlation to any events that might occur. So the PO2 measurements are also quite useful if you go into the higher echelons of the multimodal monitoring to give ideas about the state of the autoregulation in a patient, and that related to vasospasm, because subarachnoid hemorrhage do cause disturbances of the autoregulation, as we all know, and you can reduce the delayed neurological deficit by maybe by measuring DPO2 readings in this patient. For this, there's a new parameter. If you want to read about this a bit more, the group of Jäger and Josnika from Cambridge, they are very good at that. They have published a load of papers about this so-called ORX and PRX and so on. That these are actually reactivity indices of the tissue. This means that here sorry, this is in German, I didn't find it an English one. It was the continuous monitoring of cerebrovascular autoregulation using PO2 pressure reactivity index, and they found that a patient in patients, if the cerebral perfusion pressure goes down over a course of 60 minutes, the ORX, which is an integration of the curve under the line of all the PO2 measurements over a certain time, so quite difficult, and you need a computer system to do this, but it's easy to do once you have the measurements, and I'll show you how we did it later. Then you can get quite a high ORX number. It is never more than 1, and the higher it is, the less the autoregulation is intact in those patients. And in patients where the cerebral perfusion pressure is relatively stable, the ORX is quite low. So again, the higher the ORX is, the less intact is the autoregulation. So to conclude this, the PO2 monitoring offers a real-time and stable monitoring. It's a simple interpretation. If you aren't going into the integration of data, of course, but the actual measurements are quite simple and easy to interpret. It it is easy to adopt in the clinical life, and you have some easy, or simple measurement cutoff points, and you can use this method to help you with your decisions to increase the treatment of patients, for instance. How do we do it? In patients with in our patients with on the intensive care unit. If you have an awake patient, we do the normal clinical status. We do a transcranial Doppler. If the alertness is impaired, these are our patients with subarachnoid hemorrhage, for instance. We look at optimizing the CPP, and we do imaging routinely and on specific days, and we do ICP measurement, and we add the PO2 measurement, and the threshold for intervention in our unit is a PO2 less than 25 millimeter mercury, and ICP of higher than 15 to 20. Lets us start gives us a starting point for an intervention. The last thing is the traumatic brain injury therapy. If you look at traumatic brain injury, there are loads of publications that actually show that there is a good value of PO2 measurement in addition to ICP measurement in patients with traumatic brain injury, like this one, for instance. And they found in 43 patients that the likelihood of death is increased because they measured the PO2 the PO2 values in all the patients. So all their patients with traumatic brain injury, and the likelihood of death increased with an increased time of PO2 of less than 15 millimeters mercury, and the death likelihood, the mortality increased with any episode of PO2 less than 6 millimeters. So this gives us two good cutoff points when we actually have to start or increase our interventions. So this PO2 measurement versus the other modalities of O2 measurement. Again, the PO2 is more suitable. In this study, it was also the Berlin group. The PO2 measurement is more suitable than the jugular vein saturation measurement in these traumatic brain injury patients. So here, for instance, when to make a decision for decompressive craniectomy, so you can actually see, if you look at this little bit here only, this is the PO2 measurement, and you can see when we measured these patients, and we took the patient to the OR. When you open the skull already, the PO2 goes up. Then when you incise the dura, it goes further up, and then it goes up and up and up during the operation while you do the hemicraniectomy. This point, for instance, is a reduction of catecholamine by the anesthetist, and you see instantly the blood pressure goes down, and the PTO2 goes down as well. So this all leads to the conclusion that the timing of the decompressive hemicraniectomy can be guided by PO2 measurements. But it's important to stress that you cannot only take the absolute readings, you have to look at the time course in the individual patient, of course. And these studies are, again, showing this. If you look at hyperventilation, hyperoxemia, for instance, here in this is in chimpanzees. If you look, they are hyperventilated, and you can see hyperventilation, which is commonly used to reduce intracranial pressure, for instance. You do see that the O2 pressure in the tissue goes down, so it is potentially dangerous. If you increase the oxygen, it goes up. So you can see there's a very good correlation here. Okay. So hyperventilation is potentially dangerous and should be avoided if the PO2 is not monitored, and that's because it can constrict the cerebral blood vessels, and the possible results could be hypoperfusion, ischemias, for instance. So you can use PO2 monitoring to guide hyperventilation, for instance. There's a couple of studies that proved this as well. So again, a couple of words about the treatment endpoints, basically about the measurements that people should know if they use this method. The longer the PO2 is less than 15 millimeters mercury, the higher the rate of fatal outcome is in your patients. And this is from a couple of different studies that have been done from the university hospitals in Rotterdam and Berlin a couple of years ago. There is an additive effect of episodes of less than 5. They said 5, I said before 6, but that's basically the same. Increased the fatality rate, and the number of hypoxic episodes of PO2 in the brain tissue of less than 10 millimeters mercury is directly correlated with a bad prognosis. So this is again the study I just mentioned, and they saw that cerebral hypoxia is very frequent in a traumatic brain injury, and it has a close correlation with neurological outcome, and no significant correlation necessarily with ICP and cerebral perfusion pressure. So yeah. My own experience in our hospital in Berlin and at University College London, we looked at a couple of patients in a study, and in order to find out which are the cutoff points in PO2 measurement, and we found that a PO2 of about 5 to 10 millimeters mercury correlates with an unfavorable outcome, and the PO2 under 10 millimeters mercury and the CPP, the cerebral perfusion pressure, under 60 at the same time correlates with the fatal outcome. So we said that we could conclude that the PO2 monitoring is a reliable and stable method. We apply it for early diagnosis and monitoring of hypoxic changes, and if you put a PO2 probe in CT normal, and that's important, in CT normal appearing tissue, and you measure below 15 millimeters mercury, this is correlated with an unfavorable outcome. And if you have a permanent measurement below 10 millimeters mercury, you have a very high correlation with the fatal outcome. So the normal value in the brain tissue is roughly 25 to 30 millimeters mercury. So this is how we do it in traumatic brain injury patients. We measure the normal measurements, blood pressure and so on, which are normally done on an intensive care unit, and we add an ICP and a PO2 monitoring device if the GCS is below 8 and the patient is intubated. And if we don't have a specific site we want to go to because we do see like a subdural or a specific area that is injured, we use the right frontal lobe to insert the probes. And the goal is to monitor the efficiency of our treatment. Endpoints are CPP above 60, so we want to achieve cerebral perfusion pressure above 60 millimeters mercury and a PO2 above 15 millimeters. So now I come to the end of my talk. I want to talk about a couple of other things that can be measured quickly, but only cursory. Transcranial Doppler is well established for the assessment of cerebral vasospasm, can be included in multimodal monitoring. and should belong to standard neurosurgical methods. It is very fast and cheap to do this, and especially we use it especially in subarachnoid patients, of course, to monitor the development of vasospasm. And the contras are, it's a very subjective interpretation. Often you need to have a certain level of training to do this. And sometimes the monitoring systems are difficult to adjust to reading the TCD values, and the permanent transcranial Doppler, continuous transcranial Doppler, is quite challenging practically. I tried this for a while, and it's quite difficult to put the probe on and keep it in place so you get good data all the time. But it's possible, but it's very difficult. Microdialysis, another method that's increasingly used, but still it is very time and resource consuming. It's rather expensive. You need a lot of expertise to interpret the data, and it's probably something to look at in the future. But for the normal neurointensive care unit, it's probably not the first method of choice. Okay, because you look at the lactate pyruvate ratio, for instance, and so on, but it's difficult to interpret. My last two images, how do we put this all together? ICP, PO2, TCD, for instance, and
Dr. Jorn, could you wrap it up?
Yeah, it's only two more slides. It's only 2 more slides.
Okay.
So you can actually see that this is actually my monitoring system. So we use the standard laptop. There's a software being developed by the guys in Cambridge, which is basically an integrator of all the measurements, and you have an AD switcher here where you put the analog data in and change it into a digital system, and you can visualize it here, and then you can do those things like ORX, PRX that I was talking about before, and go into depth with this. So, but it is quite difficult to set up at first, but once it's done, it's stable and easy to use. And you need a computer, you need that AD thing. That's about what, €1,000, and you have it up and running. Can use it for patients repeatedly, of course. So, and then you can even do these things. If you have a proper computer, you can use your images, you can use enhanced images like perfusion images and so on, and you can put the data that you have measured with your system in this image, and you can get a good idea how the treatment and the condition of the patient is actually developing. Last picture, information overload. I mean, if you see it look at all of these things, you can see it's very difficult to look at all of it at the same time. So I would always recommend do multimodal monitoring. Don't only rely on one parameter, but don't do everything, because if you do too much, it's going to drive you mad. And that's it. Thank you.
Okay, thank you very much, Professor Jorn. Professor, I have 3 questions or 4 questions about the lecture, about the monitoring. The first one is that, the ICP more or less homogeneous in the brain, wherever you put the ICP. There is some sometimes there is some variations. With the oxygen probe, it's very regional. If you have it in the ischemic area, then you have very low reading. If you have it in the non-ischemic area, you have high reading. So if you do it in an infarction or a compressed area or ischemic area, so you'll have different reading, and you might, for example, draw conclusions which is not really necessary. Like, you say, for example, I have to do decompression, but it's small infarcted area or a small. So this is like, I think it's a problem as well, no?
It's a problem, of course. I completely understand. It's a good question. The problem is, as I said in the beginning, ICP is a relatively general parameter. So the ICP is relatively stable all around the brain. But the PO2 measurement, if you do it, like I said, with a tissue probe, is rather localized. And you always have to take into consideration where your probe is. But also the special patient. So what we try to do, as I said, if you have a general brain concussion or contusion, for instance, brain swelling, you put the PO2 probe in the frontal lobe. That's the easiest. That's a relative good correlation. If you have a localized problem like an infarct, of course, you shouldn't put the PO2 probe into the infarct, and you should actually put it not in the normal tissue, but you should put it in the tissue that's basically at risk of damage. So you should actually see, okay, let's say there's a right frontal infarct or bleeding and or contusion, and you put the probe behind that, because what you don't want is that infarct to increase. And then you can actually use that probe to do this measurement.
So you have to be very selective where you put the probe, yeah. Okay, the other question is that, did you find any discrepancy between the ICP reading and the oxygen probe?
Well,
like, yeah, sometimes you find
it is very interesting. I couldn't really go into this deeply here because it's already quite long.
No, I mean, could you find hypoxia with normal ICP?
Yeah, that's what I was
normal perfusion.
Yes, that's the thing. The problem, I did a study once. We looked at patients who had traumatic brain injury, and we were constantly monitoring ICP and PO2. And the outcome, and that was the interesting bit, was that if you look at the curves, the PO2 goes down first, and only a bit later the ICP goes up. So people always measure ICP, and then when the ICP goes up, it goes up fast. But the PO2 goes down first, and then there is an interval, and then the ICP goes up. So that's the main point of this. If you put in both probes and monitor it, you can see the PO2 goes down, and the ICP only slightly goes up slightly, and then it shoots up. If you know a patient is at risk and you are on the edge of, do I do a craniectomy or not, and I see the PO2 going down, I take that patient to the operating room.
Okay, did you have cases that, low PO2, PTTO, and normal ICP?
Well, the ICP is usually high normal, but you can see if you put both probes in as I said, we had those patients, and we saw that if you look backwards, the PO2 goes down first. So then we switched our treatment scheme and said, okay, in traumatic brain injury patients, we put in ICP and PO2, and when the PO2 goes down, we take the patient early to the operating room and do a big decompression. Yes.
So my question is that whenever the PO2 goes down, the ICP has to go up.
Oh, you have to look at the complete picture, of course.
It has to go up. There's no cases that it remains the same or without changing.
Well, the problem is if you look at the PO2 and it goes down to pathological readings and stays down, that shows you there's ischemia, and ischemia automatically results in an increase in pressure at the end.
But this is all.
It's followed by ICP. It depends a bit on if you have a localized infarct, a small one, maybe you don't have a big effect.
Okay, this is all assuming that the patient oxygenation is good, like his lungs, his oxygenation, his everything is good.
Exactly. That's why you have to do both. But one could say, oh, why don't we just leave the ICP and do the PO2?
Exactly.
That's dangerous. That's not good, because often the PO2 goes down, and you just have to see what's the problem. Why does it go down? And you know, the thing is, if you, for instance, a normal setting, what happens is you have a patient on the intensive care unit. On the edge, they change the adrenaline, the noradrenaline, for instance. So the blood pressure drops. Suddenly the PO2 drops. If you run to the operating room and they call you at night and say, oh, the PO2 goes down, and then you have to first look, why? What did you do? Did you change anything? Did you do anything? So you look at both. And if the PO2 is if the ICP is absolutely normal, I would probably wait a bit and see whether there's a trend going up. But if the ICP is slowly going up and the PO2 is going down sharply, then I would probably make a decision for intervention.
Okay, and that's why you need a combination of both of them, the ICP and the PO2. One of them will not replace the other one.
Yes, of course.
Yeah.
That's why it's called multimodal monitoring. That's why I would do both. So no, I wouldn't just do one of them. I mean, the thing is, of course, in patients with vasospasm, that's slightly different. Of course, you have to look in these patients. I mean, in the end, what we did was, or what we do is, if we have a patient with aneurysmal subarachnoid hemorrhage, and we put a PO2 probe in, you have to look at the patient, of course. If you put the probe in and the probe is absolute, it shows you that the patient has a reasonable amount of oxygen in the tissue for a certain amount of time. And then suddenly, in the middle of the night, that patient, middle cerebral artery area, for instance, and suddenly the patient's PO2 drops or goes down in the middle of the night, and there's nothing else that explains that. I do take that patient where we know that he's at risk of vasospasm. We do take him to the angiogram and do some nimodipine.
Yeah. You know what I feel. You know that the PO2 is very good prognostic and follow-up thing. But correlated more to the clinical is the ICP more accurate.
Of course.
Because the PO2 could have many variables. Could have, for example, and you don't build any clinical any decision upon it. If the patient have vasospasm, nothing you can do. If the patient has
you see things.
No,
the patient has vasospasm. If you find the problem is, I mean, I have taken patients 3 times. I have sent patients. They love me for it, but I sent patients to the neuroradiologist for intervention for nimodipine vasodilatation, like over the course of the term 3 times, because it was very sensitive, and the PO2 went down, and then they took him to the angiogram, they opened the vessel, went up again. Then after a day or 2, it went down again, up again. And then that acute phase was over, and the patient recovered.
Okay, no,
so there is a benefit.
Yeah, you can do things which is medical, like, hydration and nomidipine and so. But what do you do other than that? Like, surgically, nothing you can do. But it's good for... Yeah, it's good for follow-up and for... Okay, Professor Awad maybe has some questions. If you have any question to Professor Awad for Professor Yorn, please.
Mohammed, you have to turn your thing on.
Your mic, Professor Awad.
Yeah. Sure, yeah. I would like to thank Dr. Jordan for this refreshing information about the neuromonitoring, and thanks Dr. Hassan for leading this session. Basically, I'd like to have a comment, and then I have a question. For my comment is, when we do surgery or we do monitoring to give a decision for surgery, we are going to make volume changes and the pressure changes. So as Dr. Hassan said, I will be interested more in the ICP levels rather than the saturation levels as an indicator for the prognostic value for my intervention. Because if I'm going to open the skull, my first aim is to release the pressure. So I must have a clue that there is increased intracranial pressure. So again, the values of the ICP readings will be more valuable for me rather than the saturation or the BO2. The second issue is the world now is going to less invasive techniques. And of course, we know that we have many non-invasive techniques to detect the ICP, especially for the patient under sedation or the comatose patients. And the idea of measuring the ICP for those patients is to detect the deterioration before the clinical deterioration. If I'm following patient with conscious level assessment every minutes or every hour, then the conscious level usually deteriorate way ahead of, the deterioration happens after while from the increased ICP. So I need to make intervention before the conscious level becomes worse. This is the idea of making monitoring. So the non-invasive techniques like the transcranial Dopplers and the calculated ICP parameters, I can use the mean arterial blood pressure, pulsatility index to detect the increase in ICP. And me personally in my practice, and I have published work on this, that the transcranial Doppler and the estimated or calculated ICP is quite effective as the direct invasive ICP measurements. My question for Dr. Jorn. You mentioned in your first slides that no replacement for the clinical examination. So if your readings are going for low oxygen tension and high ICP readings, will you go direct for surgery or you make clinical assessment before you push your patient? Because sometimes it will be late intervention or no value of the intervention, and this increases the many bad outcomes from decompressive craniectomies because they are basically done for helpless or hopeless patients.
Exactly.
Second issue, because when I start to do the monitoring, some protocols depend before going to surgery, like the hypothermia techniques, like brain suppression. So you think that if I am doing ICP monitoring without using the other alternative techniques for lowering the ICP, so in centers where they don't have the hypothermia chambers or we don't have the brain suppression facility, do you think the ICP monitoring invasive wise will be of value to skip these techniques, or we consider whatever increase in the ICP is an indication for surgery if I don't have the other techniques for lowering the ICP? Thank you.
Okay, thanks for the question, Scott. It's a lot. The first thing is, I would say, yes, absolutely. As I said in the first couple of slides, the clinical examination is crucial. Definitely, you have to look at the patient. This is important. If you have someone calling you in the middle of the night and saying the patient's ICP is going up, and the patient is basically absolutely fine, relatively fine, you wouldn't rush him to the OR. You have to look why could have. There are other reasons for it to go up. The thing is that you don't put an ICP probe in a patient who's awake. So this is the first thing. So you would not measure PO2 or ICP in a patient who's awake. Sometimes if you have a patient who has recovered after being unconscious or intubated and ventilated, and they still have the probe in, then it can happen that the ICP goes up. And then you say, oh, they call you and say, oh, the patient's getting worse. What should we do? And you say, well, the patient is awake talking with you and the ICP is up. So what's the point? You don't do anything, of course. But what we are talking here is about patients who come in acute trauma and they had to be intubated, they have to be ventilated. So the problem is your clinical examination is possible up to a certain degree, but you can't really tell anyone about the conscious level. And you have to sedate the patient. Sometimes you look at the ICP and the patient just needs to be sedated. That's all you might need to do. And the patient is otherwise stable, otherwise fine, ICP is going up. So you do sedate the patient. So then what I don't like, for instance, is people coming into the ICU and the neurosurgeon on call says to them, give them mannitol 6 times a day. That's not good. That's not necessary. This is wrong, actually. You can do this if you don't know how to monitor the patient. But if you can monitor the patient, if you have actually a measurement that can guide this, you can actually reduce the amount of mannitol. Because we all know if you give too much mannitol, after a while, it works, but after a while it won't work, and then it messes up everything else. So you want to be really careful with this and only give it when necessary. So patient is intubated, ventilated, and if you have an ICP probe, put that probe in, and then you say, well, if the ICP is over 25 for more than 10 minutes, call me. And then you look, was the patient, was there some suction? Did they do anything? Did they turn the patient? Was there stress? Then how is the sedation and so on? And then if this is all fine and the ICP is still high, give them more mannitol. Then you can guide this therapy by your measurement. So I do with my talk, I did not want to say that PO2 replaces ICP or anything. If you have ICP, and that's probably the first step, if you want to do monitoring, start with ICP, because this is easy. And if you don't have an ICP probe, use a ventricular drain. That's why I said this. It's very easy. This is the easiest way of reducing the ICP, because if people have ventricles in the scan, put a drain in. When the patient is bad, had trauma, and you don't know, and you expect the ICP to be high, you don't have a monitoring system, put a drain in and put a pressure transducer on. Easy, and you can have a measurement. The problem starts when the CSF is out and you don't have any ventricles to measure. Then it doesn't work. But ICP is always the first one. And then if you can, and if you want to go deeper into this, and if you want to improve the management, add the PO2. And add the PO2 in certain cases where it actually helps you. For instance, if you have a patient who is on the edge of having a hemicraniectomy done, you're absolutely right, Mohammed, that patients are often operated when it's too late. They just can't make the decision. They lay around, and the next day the consultant comes in and they say, oh, the patient has been bad, and the pupils are already wide, and then they take them to the operating room. What's the point? You have to do it when this cascade is actually starting. And we do know that the ICP goes up and then it goes really up. And you want to do the hemicraniectomy before that curve up occurs. So the earlier you do that, the less damage is done. You want to do damage prevention. You cannot prevent it always, of course, but there is probably a point in those couple of hours that you can instigate your treatment, that you can start that bit earlier before damage has occurred. And for this, PO2 monitoring is useful, because I have seen, and a lot of people, we started this a couple of years ago, but there are loads of I've got a load of, if anyone wants that, I can mail them the list. There are loads of literature. I took it out because otherwise the talk would have been even longer, but there's loads of literature about this, that it is known that the PO2 goes down first, and it drops and it stays down for a while, and only then the ICP goes up, and then it shoots up, and then your PO2 is useless because it's down, it's 0, it's 5, something like that, and then you have an infarct. And then you would actually, if I go back to Professor Jarber's remarks, if were to put the probe, I have put in patients with subarachnoid hemorrhages, with infarcts due to vasospasm, if you do a repeat scan, and you see that if you see the PO2 is down, and you do a scan, you see the probe, the infarct got bigger, then you can take out the probe and put the probe, a new one, further back. And you want this as a it's useless if it's in an infarct. You don't need it there. you can take it out. But it does help you in certain patients, not all of them. And I don't say that we will save everybody, this is not the golden bullet, but it is a little stone in our fight to make the outcome of our patients better. And every little bit helps. And I think this is what this is all about.
Yeah, I agree with you. Like, all this monitoring really it made a difference. But I think one of the most thing, the most important thing to make a difference is you have the setup. If you have a neuro ICU, this will change the outcome altogether. Because like with regular ICUs and monitors and ICPs, it needs it will help, but you might not get the reading in the right time. So the whole purpose of having the ICP monitor is not there anymore, because by the time they read the ICP, they call you whatever, and so the delays. So, but anyway, if you have ICU, neuro ICU, you'll have better outcome, and you'll need all these gadgets.
That's true.
But it's
But let me tell you, we had that discussion in the beginning. We had a couple of ICUs in my hospital, in my last one. We had a surgical ICU, where the neurosurgical patients were located, and we had like a medical ICU, which we have in Jeddah as well. And so the thing is that in the end, the ICP monitoring was used more in the medical ICU, because what we did was we trained the neurologists to think about it. And if they had people with CVIs and they said, oh, can we put in an ICP probe? So they called the neurosurgeon, and we went to the medical ICU, and we put in the ICP probe and tell them, let us know if the ICP is higher than 25 for more than 10 minutes or so. Then that's easy to, even for someone who is not a neurointensivist, but you can use it. And I mean, I do agree that everything else, that like multimodal monitoring and PO2 and all this, is rather difficult for someone who has never done this and who has no understanding of the physiology behind that, or not a deep understanding. It's quite difficult to do this. But ICP monitoring, in my opinion, ICP monitoring is possible to be used in a normal intensive care unit if you train them to use it. It's only like 2-3 things they need to know, and if you tell them, this is what I want to know, if this patient's ICP is going higher than so and so, let me know, call the resident, and then we might discuss it at least, and that's the first step, and that would be easy.
In North America, the neuro ICU, the ICP monitoring is really in all patients, like unconscious patients or sedated patients. So even children, like fontanelle ICP, subarachnoid bolts, it really made a difference, because I lived that thing, and they, every time there is a rise, they call you, you go and do, as you said, the simple things first, sedation, hyperventilation, monitor, whatever, and they go down. The outcome is really, benefited too much from the early interference and management. Not all of them, they needed surgery. Maybe very few needed surgery. But whenever you have the first alarm and you intervene, and this is the time, they drop the ICP and the patient will improve. So they can get out of the hard time, they can sail through this critical period. Because if the ICP is run off, it's too late to do anything after that.
Yeah, the thing is, if you have patients, I mean, we always say we want to make the decision about interventions, but also you could look at it from the other side. You could say, well, a hemicraniectomy is a huge intervention, and it is traumatic. If the patient survives, it is traumatic for them. And sometimes, it's like a fluctuating thing, at least in Germany. There used to be a time where everybody was doing hemicraniectomies all the time. Then suddenly it got out of fashion years ago, then it came back into fashion. So it's sort of a wave. And to in the end, if you don't do monitoring, what you look at the image and see, oh, there's contusion, or I better do a craniectomy. And sometimes you don't need to do a craniectomy. Just put a probe in. The ICP is actually relatively normal, and you can save that operation for the patient. So you can save the patient from the neurosurgeon.
Actually. I think decompressive craniectomy means that you missed so many early signs to intervene early, and you reach the point that you need decompressive craniectomy.
No, but sometimes it goes there and you can't do anything else.
No, I mean, if you have the early signs, early warning, and you intervened with the other measurements, okay, you might not reach that point that you need craniectomy.
Yes, yeah.
Of course. But it depends mainly for decision making on the initial or the zero GCS for the patient and the follow-up after stabilization.
Yeah.
If you got patient who basically after trauma, at the time it was attended, GCS is 4, then he progressed to 5 and back to 4. I'm not going to operate this patient, what kind of surgery, whatever the readings of the ICP. But if I received one patient whose GCS is 10, then it after resuscitation jump it to 11, then it's back again to 9. This patient I'm going to operate because the initial GCS was okay. So the initial assessment is very crucial for the decision making and the initial GCS. I have two comments for the ICP monitoring because most of the time we've been called for increased ICP and we found simply the patient is recovering from the muscle relaxant or the tube is kinked or full of secretion. It happens most of the time. And the most important note I give to my nurses is don't make dressing for the ICP bolt in the head, please, because most of the time while they're removing the plaster, they take out the caster as well. And it's problematic sometimes when you use the 4-channel ICP bolts like the Lycox. It's very challenging to reinsert all the things. Actually, it's very expensive. I mentioned the transcranial Doppler as a rule for assessment of the ICP. The problem with the transcranial Dopplers, it's dependent on the operator first. Second, it cannot be continuous monitoring. The beauty of the ICP is the continuous monitoring. So at any time you have continuous reading for the ICP and they can simply awake you at any time and let you know that the pressure is being rising for some time. For the measured ICP or the measured intracranial pressure, it depends on the time of the examination. Usually it's done by the ICU or the neurologist or some neurosurgeons are interested to measure the transcranial Doppler. So you make around 3 times per day, 4 times per day. At that time only, you will detect that there is high ICP, but you don't know how long the patient was in that situation. It helps, but it's not practical for the minute-to-minute follow-up of these patients. I have one question to Professor Jorn. If you are in a facility to have a patient with an organic lesion, mainly contusions, for example, for trauma, he has big left frontal contusion, for example, you will put your catheter or the tip of the electrode in the left loop or in the right loop. I mean, if you are going to use one electrode and you have left mass lesion, you put the electrode in the right side or on the left side.
Well, 2 things I'd like to say. First, what you mentioned before, the 4-channel probe. I haven't talked about this because, again, that would have made it even longer. And the companies don't like me for this, but I am a bit old-fashioned when it comes to this. I don't like multiple lumen probes because, first, they are too big. Because I said before that the complication rate for with insertion and so on is relatively low. I mean, if you look at how big the bolt is for the multiple lumen ones, I don't want to say I hate them, but I don't like them, to say it like, because First, I don't like those big things being poked into the brain. So I like the small probes first. And second, I like separate probes, because sometimes if you have a PO2 probe that doesn't work or that you have to replace, the thing is, an ICP probe is easily, if that's in an infarct, and that goes to your second question. If an ICP probe is in the lesion, and you haven't done any operation before, you still measure the ICP relatively accurately. And but the PO2 is useless. So I usually use separate probes and put the PO2 probe according to the CT scan, where I could actually get some useful information. So, so in general, to come to the second, that's one thing. And then you can also change it around. If one is broken or it has to be replaced, it's easier to do with the small and single probes. And second, it's cheaper in the end, and because you don't always need all probes, so you know, it's better. So then to your other question, well, it depends on the case, of course. But if you have a patient with a left frontal contusion, I would, it depends what I want to know. If what's the accident, if that was like an RTA, a frontal collision of the head, and I'm afraid that the other side would also get would also develop a contusion, then I would probably put it on the other side, or I would even put two, but I probably would put it on the other side. If it is a localized left-sided lesion, I would try and go to the side of the lesion, because it is slightly, because you do have the falx. I mean, I said before that in general, the ICP is relatively the same in the supratentorial area, but of course there are differences, and the whole thing gets really complicated if you have done any intervention before. So, because if you, for instance, put a probe into a patient after, some people did that, I don't know why, but they do. If you put an ICP probe into a patient who has had, or during the surgery, who has a hemicraniectomy, you can use the readings, so you can may as well leave that, and I don't really do that. PO2, yes, but not ICP. So ICP I wouldn't put into patients who had an operation, because you can't really use the readings. If the contusion is completely devastating and this side is lost, but doesn't need to be operated, I would probably put it on the other side to prevent damage to that. But then I would include a PO2 probe as well. Did that answer your question?
Yes. Professor Hassan, I think we have some questions coming from the audience. So can you pick up some of the questions? And
I don't know why. Professor, I don't know, for whatever reason, they're not coming to me. I am opening.
I can see some.
So if you have them, go ahead, please, Professor.
Yes. So, Jorn, there is one question about the cases with infection and complications with bleeding and the treatment regimen.
What about cases with infection and low blood pressure leading to?
The question is not clear, but you can elaborate on the infection.
In fact, I don't really know. Okay, what about case? Okay, I guess whatever that colleague asked is, they asked about patients with infectious diseases. Well, I mean, I wouldn't put a probe into. I mean, if you have. I don't really know what this question means.
What infection? Meningitis?
After insertion or before insertion? The infection. I mean, if you talk about meningitis and brain swelling, then there is a point of putting a probe in, I would say. If the question means if we have more infections, I have never seen a case of infection after insertion of a PO2 probe in all those years.
Usually they are staying a short time.
Yeah,
people
but I
are
don't
not
know.
taking the ICBs for weeks. It's only 1, 2, 3 days until everything.
Exactly.
So
And the PO2 is very small and it doesn't infect. No, in fact, I've seen one infection in 20, I don't know how many years I've been doing this. No, it's one infection, but very, very low. PO2, very low. ICP, the bigger the probe, the bigger the operation, the higher the infection. And of course, if you use an EVD for measuring the ICP, of course, you have a higher rate of infection.
Yeah, we have another question. Yes, we have another question from Ines, I think. Can electrogram detect the oxygen consumption of the brain and the oxygen pressure?
Yeah.
She's asking if the EEG will help.
Yeah, well, it is interesting because there is a spreading depression. That's what that probably points towards. There are some studies about electrical phenomena on the brain, and they are useful. And but you can detect changes in the brain metabolism. Let's say it like that.
Can I
wouldn't automatically do an EEG.
Yes, Professor Hassan, please.
Yeah, you see, there's difference between monitoring and measurement. Okay, what the probes are for monitoring, like it's minute by minute, monitoring. The transcranial Doppler, EEG, whatever, these are like diagnostic measurements at that time. Okay, but here we are talking about monitoring, like we have the patient under continuous surveillance, like you see his PO2 continually and you see his ICB continually. So you can do that, but it's not really monitoring. I just want to go back again to the infection. I think in case of infection, especially ventriculitis or meningitis, maybe the ventricular catheter is more valuable because you can do cultures as well, like cultures and measurements and whatever. So if you really want to measure, you can do the ventricular catheter. And some people think ventricular catheter by itself is measurements. No, it needs transducer. Without transducer, you will be just what's called rough measurements by saying the height of the column or how high you put the catheter, the tube itself. But if you really want to measure, you have to have transducer.
Yes. Yes, you need a transducer. That is usually what we use. Is we use a
transducer.
That is for the arterial pressure, for instance. You can use that as well. And the good thing in infectious patients is that you can get a CSF out of your probe, of course, out of your
for
drain.
Analysis, cells, and whatever.
You can actually, although that is not always accepted, do some treatment as well. Some people give vancomycin, but it's more experimental. But that's also possible, of course, if you have ventriculitis.
Okay, Professor Hassan, there is one question. I think you can elaborate for it. Pupillary assessment is the best tool in neurological assessment. I like this question because it's a clinical one. So I need your input about this, please.
Yeah, you see, as the Professor Jorn said, like, this monitoring is for unconscious patients or sedated patients. So clinically, you will not have more than the vital signs. So if you're reading the blood pressure, the bradycardia, these are like, good measurements, but sometimes a little bit late. And there is other factors that intervenes as well, like, because like, there's other reasons for hypertension. And, but, if you're really very meticulous with the blood pressure and the bradycardia, you have to tell the team in the ICU your parameters. Like, for example, call me if the pulse goes below 60 or 55. Call me if the blood pressure goes. And then you can see what's the cause. Like, is it something you can treat by itself or not? But clinically, to test the patient itself, usually sometimes we give windows, like, so anesthesia windows. Or the best thing for unconscious patients is that you give them minimal sedation, not to pull the tube. Never give them like, heavy sedation. Don't let them like, anesthetize them. And just painkiller and minimal sedation so they don't pull the tube. And then you have some window of clinical. But patients who are completely sedated, there's no way you can follow the clinical, other than vital signs, you cannot.
And also
the exception is one thing, the post-operative monitoring. Like, sometimes some people, like, after brain tumor, after hematoma, after whatever, they put ICP monitor, and so these ones, okay, you can assess clinically, like, the patients, but as soon as the patient is awake, you don't need ICP monitor for them usually, because risk of infection and so on.
And they wouldn't like that anyway. I mean, first, if a patient is awake and you try to put in a probe, that's not a good idea. And if the patient wakes up and is more or less awake, and you can actually do proper clinical examinations, you can usually take out the probes.
Yeah.
But the pupil, the question was about the pupillary assessment as well. It is of course, it is a neurological tool, but when the pupil goes wide, it's usually quite late in the process. And that's the whole point, that we get it before this happens. Because if the pupil goes wide, and then you have to do something fast. And so if a patient is bad and then suddenly gets worse and the pupils are wide, then you better find out what the problem is, because either you do something then and there, or you can probably leave it.
Yeah, they have the window, but you need somebody to look at the pupil in the right time, because if you can see it like after half an hour or 1 hour, you miss the
Exactly.
They're not going to keep looking at his pupils like 24 hours, like
That's the reflex of neurosurgeons, that always after the surgery, even if I operate someone on the neck, I look at it.
Yeah, but anyway, like if you read the pupils really early, like in time, you still have a window, like you can do mannitol, CT scan, hyperventilation.
But all I'm saying is that the pupil is usually quite a serious late sign. So if the pupil goes wide, then you better rush into the CT scanner before you
scan, or you have between 1 hour and between 30 minutes and 6 hours to act quickly,
if you're lucky with the
so I have question for myself. Apart from trauma, if you are doing ETVs or endoscopic third ventriculostomy for hydrocephalic patients after posterior fossa lesions, hematomas, or forced ventricular tumors, when you will use intraventricular ICP at the end of the procedure, you use it, or you just take out the endoscope and don't put anything in the ventricles to monitor how success is your?
If I'm afraid, what I've moved into is like because you have a big, if you do like an ETV, for instance, a third ventriculostomy, and you're afraid that there could be a problem, I sometimes leave a drain in for a couple of days, close it, but leave it in, and that gives you a good idea. So because it's there, you're there, and then you pull it, I tunnel it, and you pull it out, put the switch over. Safe
don't
procedure.
consider it as a ventricular ICP monitor. Will not connect to the.
Well, you can do it, but I mean, what? No, I wouldn't. No, I would just leave a drain in, and because what you do is you have the patient is usually awake afterwards. You wake the patient up. So this is the best thing anyway. If a patient is awake, you don't really need ICP monitoring. So that's what I always tell them and teach them. If the patient is awake, do your clinical examination.
This patient came by headaches, or sometimes they came disturbed conscious level, and you don't expect immediate recovery if they are coming in the casualty. So the patient will recover after 1 or 2 days when the tension settles down. Yeah. So what you do in these issues?
I often put in an EVD.
I put a shunt.
No, don't say that. Don't teach anyone that. That you don't need to do your ETV. So don't put in a shunt, especially not in children. If the children are young, your ETV is going to be closed after a while. So honestly, I do put in a drain. If I'm afraid that something happens, I leave a drain in. close the drain, and see how the patient is doing. If the patient isn't fine, I check with the drain whether there's increasing pressure, because in this case, you can actually see what happens. So I don't necessarily put in a probe. Because if you have a probe, what happens is you go, if the ICP goes up, then you run to you have to do something anyway. So and what would you do? You would probably put in a drain. So I leave the drain in, close it, and in case there's trouble, I open it again. That's it. And then it takes one clip. And otherwise, if you put a probe in and the ICP goes up, what are you gonna do? You have to drain the CSF.
You know, the talk is very enjoyable, and we can spend a whole night talking about it.
Yes.
But you know, Dr. Awad, if you have some last comment, and then Dr. Jorn, the last comment after that. Dr. Awad, if you have last comment, and then we can close up.
Yeah, thank you, Dr. Hassan, for chairing this session. Thanks for my Prof. Jordan for the nice presentation. The most important is we use, as we take from the topic itself, it's multimodal assessment of the patient. Use both the clinical examination, use whatever monitoring tools from regular blood pressure monitoring, the saturation of the patient, the pulse of the patient, together with the invasive monitoring tools if you have, like the intracranial pressure monitoring and whatever kind EEG monitoring. All this will help to decision making, but again, it depends on proper analysis of the data, proper patient selection, and the proper utilization of available tools, and of course training of the surrounding stuff. Thank you.
Thank you, Dr. Awad. Professor Jorn, any last comment?
Just a last word. I hope this wasn't too theoretical when I was giving the talk, but I had to do a bit of theory, otherwise it doesn't show why we're doing this. And I hope that people, at least after this lecture, start thinking about the possibility of these methods. And if they want to improve something, I would say start with ICP. And if you can do this, then go on, and you will see it will let you sleep better at night, and it will be much better for your patients in the end.
Okay, my last word for it as well. Like I was at the time when they were developing the oxygen monitoring in Germany, and they came with all different kind of measurements: lactic acid, glucose, chloride, sodium, carbon dioxide. I think the only one survived is the oxygen one. The other ones did not really stay. Anyway, your talk was very deep practical, actually. It's not theoretical, very deep practical, and really it's very important for everybody, as Dr. Awad said, for the staff, for the patients, for everybody. And we hope that every hospital can arrange, what the atmosphere and the what's called the start using it, but you need that to train your staff and update your ICUs. But it makes a difference, actually, as you said, Dr. Professor Jorn. It makes a difference in the outcome of the patients.
And don't be afraid.
Thank you very much for your talk, and nice to see you again. And Professor Awad, thank you very much for participating. Professor Ayman, he apologized. He had an emergency case that he had to go. And I'm really sorry for the audience. I really couldn't see the questions, but at least Dr. Awad, Professor Awad get the questions, and Professor Jorn. So I hope everybody enjoyed it and learned something. And maybe if you have, Professor Jorn has an email. If you have any questions, you can direct it to him. And he can, I hope he will have the time to reply for you one by one. Okay. Thank you very much, everybody. And we'll say bye-bye.
Okay.
Thank you.
See you, George. Bye.
Thank you. Bye-bye.
Bye. Bye.